Good morning and welcome to Pediatrics Grand Rounds. Please mute your devices when you join, and we'll repeat the code for the CME in the chat box frequently. It's my pleasure to introduce this morning's Grand Round speaker, Dr. Angela Weyand. She's an Associate Professor of Pediatric Hematology Oncology at the University of Michigan Medical School. She attended Northwestern University for her undergraduate education before heading to the University of Michigan for medical school. She completed her pediatric residency at Seattle Children's at the University of Washington before returning to University of Michigan for her pediatric hematology oncology fellowship. Her clinical interests are in hormone-provoked thrombosis, von Willebrand disease, and the care of young women and girls with disorders of hemostasis and thrombosis. She is co-director of multidisciplinary clinic dedicated to the care of this population. Her research interests are in optimizing the care of young women and girls with disorders of hemostasis and thrombosis, as well as reference ranges and how these contribute to health inequity. Dr. Weyand, thank you very much for accepting our invitation, and we're looking forward to your presentation. The floor is yours.
Thank you so much for the kind introduction and for the invitation to present. I'm sorry I can't be there in person, but I'm excited to speak on a topic that I think is important and one that we all kind of are thinking about as we care for patients. So my objectives today, I'd like to identify some of the discrepant reference ranges that we use in hematology that are based on patient sex, race, and ethnicity. Kind of looking at the source data that inform these reference range values. Where do they come from? Is it a legitimate source where we should be actually using these reference ranges? And then also recognize how these reference ranges may contribute to health inequities within the populations that we care for. So I think that we all, as people in medicine, are probably very familiar with reference ranges. We use these all the time throughout all different fields of medicine. And they really kind of provide us the context within which we interpret and characterize results, right? Everybody's ordering labs all the time. And when we get those labs, we really are interpreting them within these ranges and whether they fall within the normal range, quote unquote, or the abnormal range. And for certain disease states, they're really, really important, right? So we diagnose patients with anemia based on their hemoglobin value and whether it's outside of the reference range, not on whether they come in and say, I'm pale and I'm a little short of breath with exercise and I'm fatigued. Though, we don't say, okay, you have anemia based on those symptoms. We say you have anemia after we've sent the labs and have that hemoglobin value return. So reference ranges actually are not as old as you would think they would be. Standardized reference intervals, or the idea of having these standards, was really introduced in the late 1960s. And so, any blood analytes were kind of looked at and thought that we should have a standard that people, when we ordered these labs, we could have a context to interpret them within. But basically what they typically entail is that a reference population is defined. And so that's defined by whatever lab is, creating the reference range. And they say, we're going to get 1,000, healthy volunteers, however they define that. And they send that lab on those 1,000 healthy volunteers, and then they make a Gaussian distribution and cut off the bottom 2.5% and the top 2.5%. But as you can imagine, that's kind of assuming that for any given disease state, for example, anemia or really anything, that 2.5% of the population is going to have an abnormal result on either end. And that's not exactly true for a lot of disease states, but that's unfortunately how we define these reference intervals. So in hematology, a number of our reference ranges actually differ based on the patient's age. So you've probably seen as children kind of grow that those CBC reference intervals change over time. A lot of the ranges also differ based on sex, as well as race and ethnicity. And whether or not we should be doing that, I think, is a different question. So thinking specifically about anemia, which is what a lot of my talk will focus on, as I mentioned, we diagnose anemia based on a hemoglobin value, not on symptoms that a patient is reporting to us or even physical exam findings that we may see. But the World Health Organization defines anemia as a pathologic condition where the number of red blood cells, or hemoglobin, is insufficient to meet the body's physiologic oxygen carrying needs. You'll note that although this is a definition that's based around hemoglobin, taking a Gaussian distribution and saying the bottom 2% and the top 2%, 2.5% are abnormal, isn't really looking at anything like physiologic oxygen carrying needs. And none of these reference ranges are based on that. There aren't studies that show if you are in that, 2.5% on the bottom or the top that your oxygen carrying is affected. So why do we care about anemia, since I'm going to spend so much time talking about it this morning? Anemia actually affects about 1/3 of the world's population. And this is obviously a bigger concern in low and middle income countries, where if we look at the whole world, over 60% of cases of anemia are due to iron deficiency, as nutrition continues to be a big issue in many areas of the world. But what we know about anemia, especially even looking at high income countries like the United States, is that when patients have anemia, it results in a lot of downstream morbidity and mortality. So a patient with anemia has increased all-cause mortality as well as cardiovascular, post-operative, post-stroke mortality. We know that this is a huge issue for mothers and babies. So we know that mothers that have anemia, specifically iron deficiency anemia, have increased maternal and perinatal morbidity as well as mortality. So this really becomes an intergenerational concern. And within even hematology oncology, we know that when patients present with anemia with any number of different malignancies, they are at higher risk of dying from that malignancy just based on the presence of that anemia alone. So thinking about anemia and how sometimes we base our cutoffs, or how we're diagnosing someone with anemia, how we're determining who we're sending additional labs on or who we're going to start treatment in. I wanted to start with a case and how this might apply, especially to pediatricians and the children that we care for. So this is a 4-year-old boy who presents to his primary care doctor, and mom says he's just been like a little more tired than usual. Seems to rest after he gets home, from preschool, and just really is not, as active as he previously was. So being, a very astute pediatrician, his primary care doctor sends a CBC, which returns with a hemoglobin of 11.1. So here on the right, what you can see is the table that previously was an up-to-date. We actually did a little bit of advocacy and got this removed, but up until about 6 months ago, this table is what you would see if you looked in up-to-date about the workup or, diagnosis of anemia in children. And as you can see here, it had basically broken down the cutoffs for defining anemia between white and Black patients. Now, as we all know, there are a lot of patients that don't fit into the white category or the Black category, but up-to-date definitions of anemia didn't account for those patients. And as you can see here, this patient actually has 1 Black parent and 1 white parent. And so, this case, I think, just kind of illustrates the absurdity of this table, or kind of basing decisions on these sorts of algorithms or reference ranges, right? So if you were seeing this child in clinic and he's 4, and the hemoglobin cutoff for Black children is 11, and so if you say, well, I think he looks Black to me, which some physicians may do, he's not anemic, versus if his parents say, no, we're white, or you say, well, he looks white to me, then he's not anemic. And again, who is making those decisions? Is this a patient that is identifying by the race? Is this the physician's, perception of the race? And that gets into a whole nother set of issues with, how we're even defining these things. And as I mentioned, I think unfortunately these things tend to be intergenerational. So a lot of times we have parents that are, we know that patients that identify as Black are more likely to be iron deficient, and that is increased even in the maternal populations. And so then their children are more likely to be iron deficient. But again, that's not a reason that we shouldn't be identifying this iron deficiency and treating it both in the mother as well as the baby. And this is especially prevalent and an issue when we think about the mothers of the children that we care for. We know that about 2/3 of deaths related to pregnancy are preventable, that patients that identify as Black are 3 times more likely to die from a pregnancy-related cause, and maternal morbidity is also quite high in Black populations as well. And so I think, again, looking at this, ACOG actually recently redid their recommendations to change from not having differential cutoffs for Black mothers compared to white mothers, which I think is really important, especially given the horrific Black maternal mortality that we have in this country. So luckily, I think with the up-to-date table, we actually were able to get up-to-date to remove this, and they now have a new table that is not incorporating race into their hemoglobin cutoffs. Unfortunately, a lot of the major textbooks that both pediatricians and hematologists still use to this day do continue to include these race-based cutoffs that define anemia differentially, and unfortunately always define anemia differentially in terms of having lower cutoffs for patients who identify as Black. So I think it's important to really discuss and talk about terms and make sure everyone's on the same page, because I think these things really tend to get confusing to people, and that oftentimes people think they're talking about the same thing when really they're not. So race is really a category of humankind that is a social construct. So this is something that we as a society have defined, and the United States population census actually defines 5 separate groups, but there are a lot of people that when they look at those 5 groups really don't find a space where they feel like they fit, and so clearly 5 groups is not sufficient. But again, this is something that's usually based on physical traits and isn't equivalent to ancestry or genetic background, but really is just something that society has said, okay, well, you have dark skin and you might have coarser hair and you're going to be within this racial group, and you have lighter skin, and these sorts of things that are physical traits and oftentimes how people are presenting. Ethnicity is more broad. It is also a social construct, but can be related to things such as race, but it can also be related to things such as religion or cultural background, and so is much more broad in terms of how it's defined. Although within the United States, many of you have probably noticed that typically when race and ethnicity data are collected, that there's just the Hispanic and non-Hispanic for ethnicity, but really, in the broader context, ethnicity is thought to encompass a lot more different groups than that. So I think what becomes difficult is that oftentimes race and ethnicity get conflated with genetics, right? And something that is a biological construct, not a social construct. And so this is just a statement from Francis Collins, who previously led the NIH, about how we really use race and ethnicity that, at their baseline are social constructs, but also pretty poorly defined, and that we tend to use them as surrogates for a number of genetic factors as well as environmental factors. And that although these environmental and genetic factors, lead to differences in prevalence of disease and how, diseases present, we really should not be focusing on race and ethnicity as the race factors, but rather on these environmental and genetic factors that are actually causing the problems, and that we should really be looking at the actual causes rather than these imperfect proxy relationships. So I had published some initially a manuscript in Lancet Hematology looking at the use of race in these hematology reference ranges and how this likely leads to health inequity, and subsequently got invited to present at a meeting of the World Health Organization where they were trying to kind of evaluate some of their materials and how they were defining anemia and what sorts of factors that they should be taking into account when they define anemia among different populations. And as you can see here, even the World Health Organization was kind of grouping these three things together: genetic ancestry, race, and ethnicity, when really they're very different concepts, right? With race and ethnicity being similar social constructs that don't have a biologic basis, versus genetic ancestry, which is very different. Of note, when I did speak at the World Health Organization, the materials they were looking at, the broad definition, as I mentioned before, for anemia does not actually incorporate race. And so within like the WHO definitions, the hemoglobin values are based on whether you're a man or a woman, but not necessarily on your race. However, they do still have materials up at least until quite recently within their materials that they provide that do differentiate hemoglobin thresholds based on race and ethnicity and kind of odd things. So this is an example. This was a table that was kind of, I think, most egregious that they put out, which basically shows suggested adjustments for specific groups based on things like age and where you're from. So as you can see here, I think it kind of illustrates the absurdity of the argument when you have, Jamaican girls between 13 and 14 years old can have a hemoglobin, of 10.7 grams per liter less. But I guess once you're 15 and Jamaican, that no longer applies, or if you're 12 and Jamaican, right? But it just is kind of an absurd thing. And what is it about Greenland? Like, why can they have a little lower hemoglobin, right? So these things just become a little absurd, and I think are just based on basically, right, they took their reference range from women in Greenland, but what do we know about the diets in Greenland? Or what do we know about, other things that could contribute to this? And we shouldn't just normalize that just because within this population, they may have a lower hemoglobin. So I really think those terms are incredibly important. When we presented, we were in a session where they kind of tried to group all of these things together. And so we spoke alongside a physician who talked about genetic variants, which I think are incredibly important, and we should be thinking about how genetic and biologic things contribute to anemia. That is what we should be focusing on, but those are not the same thing as race. And even here, this doctor was looking at SNPs, or genetic changes, but even the title of her talk was ethnic differences, which really is not actually describing the work that she's doing. But I think people even in medicine tend to conflate these terms and get them confused. But I think it is incredibly important because they are not the same. And in many ways, we're really not even, even if we say they're a rough proxy, that's not exactly correct. So when we think about genetic ancestry, it's really important to remember that this has nothing to do with race and ethnicity. The way that we have grouped the 5 race groups that we use in the US, or the 2 ethnic groups that we use in the US population census, is not based whatsoever on genetic ancestry. So this is actually from a paper in genetics looking at nucleotide diversity. So nucleotide diversity is defined as the number of nucleotide differences between 2 randomly selected sequences in a population. And what this work actually looked to do was that they took patients from the African continent, the Asian subcontinent, and the European continent, and they basically compared nucleotide diversity. And what this figure illustrates is that there's actually more genetic diversity between 2 individuals who are both on the African continent compared to an individual from the African continent and an individual on the European continent, or African and Asian continent, that basically there's more genetic diversity within Africa than there is, between Africa and other continents. So I think, again, even thinking about, I think some people think, well, probably, Black patients have like more similar genetic background, so maybe it's an okay proxy, but really we know that that's not even necessarily true. So thinking about how these reference ranges were created and how, a lot of these reference ranges that are based on race and ethnicity really date back to a single paper that was published in Blood in 2005. And this paper actually looked at about 31,000 white patients and about 1,500 Black patients. And they basically, got extensive CBC data on all of these patients and then tried to create reference ranges, again, based on that Gaussian distribution. And with this, they did say, Black patients are more likely to have thalassemia. We want to rule out patients with iron deficiency. And then Black patients also are more likely to have sickle cell trait. And so they tried to, exclude those patients when they were creating these reference intervals. Unfortunately, there were a number of flaws in this study. They didn't actually account for things like G6pd deficiency, deficiencies of vitamin B12, vitamin A, and folate, all of which have been shown to be of higher prevalence in patients who self-identify as Black. G6pd deficiency, more of like that correlate to where patients' ancestry is coming from versus the vitamin deficiencies that are more related to social determinants of health. The definition of iron deficiency that was used in the paper was pretty flawed. The paper used a ferritin of less than 10 to define iron deficiency when we have a lot of good literature that supports that ferritin levels really need to be closer to 30 or even 50. And we also know that there are studies that have shown that patients that self-identify as Black, even with iron deficiency, tend to have higher ferritin levels due to underlying inflammation. Again, likely resulting from social determinants of health that largely cause, increased stress in these populations. And so it's interesting because all of the reference ranges that are based on this paper, do differentiate patients and give lower hemoglobin cutoffs for the definition of anemia for Black patients. But the authors actually even note, that really we can't solve this problem by just establishing different reference ranges for all of these different groups. And really their rationale for that was that there's some degree of admixture within all of them. And I think thinking back to that case, that's incredibly true, right? What if you have a patient who comes in to see you and they're, they have one grandparent who's Black, but then, everyone else in their family is white. How do you determine their hemoglobin cutoff? So I think just even logistically, it doesn't necessarily work, especially in places like the United States, where we have a lot of admixture. And so thinking about, this just a little bit more from a hematologic perspective, I think when we think about anemia and a lot of the kind of worldwide causes of anemia that are related to genetic variation, it's important to realize that these are all really in response to the selective pressure of malaria. And so most of these disorders are concentrated in areas where malaria is very prevalent. And so things like sickle cell disease, thalassemia, G6pd, a lot of the memory disorders, as well as the ABO blood groups really are a lot or almost entirely due to the selective pressure of malaria within those areas. So when we think about worldwide anemia and the prevalence, as you can see here, these are just different worldwide maps that illustrate the prevalence of certain genetic conditions that cause anemia. And so, there are a lot more patients in Africa and Asia that have, some of these abnormal hemoglobins, and that's important to remember. And I think a lot of people who would like to conflate race with ancestry would say, okay, so these countries can't be expected, those patients can't be expected to have similar levels of hemoglobin as the United States, where we have far fewer patients with an abnormal hemoglobin. But what we also know is that that map really has a lot of overlap with a lot of really treatable causes of anemia. And so things like iron deficiency, vitamin A deficiency, and hookworm all have, similar increased prevalence in these areas where malaria tends to be, more prevalent, and where those genetic anemias tend to be more prevalent. And unfortunately, if we define anemia differently in those areas based on the fact that we know a lot of patients with thalassemia live there, then we may miss a lot of patients that don't have thalassemia but do have, a very treatable cause of anemia. And unfortunately, I think in a lot of countries, by, saying, well, we have a lot of patients with genetic causes of anemia, so we can have a lower cutoff and, not address this issues. It allows the healthcare system there, the government there, kind of a pass in terms of investing in things like good nutrition and clean water and things that would actually help these issues. And it's not just an issue in the, low and middle income countries. It's also an issue in the United States, where we know that patients who are Black or Hispanic have, a higher rate generally of anemia than patients that are identifying as white. And that isn't because of genetic causes like sickle cell disease, G6pd or alpha thalassemia trait, but is much more likely the result of social determinants of health, where nutrition and access to resources is more limited in these populations. So unfortunately, when they make these race-based cutoffs, I think sometimes the arguments for keeping the race-based cutoffs come from like a practical perspective, I guess is what you would call it. So one of the issues when they are defining these sorts of things, this was a report from the Institute of Medicine that really noted, when they looked at these populations of Black patients and white patients, that if we were to raise the cutoff for Black patients to the same level as white patients, that we would just have like a, practical problem with how many patients that were Black that had iron deficiency, and that would be problematic. And this was really upsetting to me, because the number actually that would have been was that like 18% of Black women would be found to be anemic, which is a good proportion, right? That's a pretty substantial proportion of the population, but again, it's a treatable condition. And I think if you think about other conditions that we see in adults all the time, 47% of adults in the US have hypertension, and we don't say, oh, well, that's practically difficult. I don't think we want to have to treat 47% of the population. So let's just change that. And now you can have, a systolic blood pressure of 150 or 160, because that way we'll just have a lower percentage of patients that are affected with it, and we won't have to, deal with the practical difficulties of having so many patients with hypertension, right? We don't say that. We don't say that about obesity. We don't say that about sleep apnea, all of which are things that have higher percentage of people affected. And so just because we can say, oh, well, these patients are Black, and we will just pretend they don't need as much oxygen carrying capacity, let's define this differently, so we don't have to necessarily treat the problem, which again is a very treatable underlying problem. So with that, I also wanted to switch gears a little bit to kind of another area of hematology where this becomes problematic. So some of you may have heard of an entity that historically has been termed benign ethnic neutropenia. It has recently been published about, and a number of authors have suggested that instead of calling it benign ethnic neutropenia, again, because it's not related necessarily to ethnicity, it's actually related to genetics, that is due to that selective pressure, again, from malaria that we know so many hematologic issues are born from. But basically what this is that we know that in some patients whose genetic ancestry is from malaria, areas where malaria is quite prevalent, tend to have a lower ANC, and that this is not detrimental to them in any way. It is not associated with increased risks of infection, but we do get a lot of referrals, from general pediatricians for patients that have low ANCs, and there's nothing specifically to do. You can do the testing to show that this is due to their Duffy null status on their red blood cell, and then you can let the family know that it's not really an issue. But what they found, historically, I think this has again been associated with ethnicity or race, when really it should be defined based on the biology that's underlying it. But unfortunately, what this has led to is that we have had a lot of Black individuals who have this condition that is very easily testable in the blood, and that once you test for that, you can say, this is fine, this is not a big deal. But unfortunately, a lot of these patients end up undergoing, invasive procedures such as bone marrow biopsy. These, bone marrow biopsies are normal. We know that a lot of times patients who have a lower ANC, some of the chemotherapy medications that we use, the dosing is based on ANC, similarly in rheumatology. And so we know a lot of these patients who are Black that have this Duffy null phenotype, which again does not really mean anything from a biologic state. It's just, they have a lower baseline. They will not necessarily be able to be enrolled in trials, or they may get less treatment for their rheumatologic disorder. And I think this all really goes back to, we don't necessarily need different reference ranges based on race and ethnicity, because that can perpetuate health inequity. But when there are biologic things that differentiate people, that we should be knowledgeable about these things and be able to account for these things. Because unfortunately, historically, most of the research that has been done in medicine has been on white men from middle America, right? And the reference ranges or the drug responses, or whatever it is that we have learned in medicine, we can't necessarily use that for this huge wide spectrum of patients that aren't white men from middle America. And so I think it's important to recognize when we have these cutoffs, for example, of an ANC of 2000, this is going to exclude a lot of patients that have this Duffy null phenotype that also tend to be otherwise marginalized populations, such as Black patients. And so this is just one study that was done in adults, looking at, basically that these patients had breast cancer, and some of them had, this Duffy null status, and that the patients with Duffy null status actually had, a lot higher percentage of those patients had dose reductions of their chemotherapy. They got a lot lower dose intensity of their chemotherapy. They had a lot lower clinical benefit because they were getting a lot less chemotherapy, and they were twice as likely to have progressive disease. Of note, the patients that had Duffy null status actually didn't have an, increased risk of infection or those sorts of things. They just had lower neutrophil counts. So again, I think, trying to be cognizant of some of these issues, and how, when we take all of our data that is based on a very specific population, that we can't necessarily extrapolate that to all of these other populations that may, have underlying levels that are different. So what can we do about the Duffy null associated neutropenia? It's been proposed to limit the term benign ethnic neutropenia from the lexicon, as really this should be something that, this is based in biology and ethnicity is not, that there should be implementation of Duffy null specific ANC reference ranges, again, based on biology. So if you see a patient and they're Black and they have low ANC, it's not that you should assume, oh, well, you have Duffy null, you should test for that. And if they have that, then say, okay, now we know this, and this is what we know about Duffy null, status. And if they don't have that, then they should require, have all of the normal workup that you would do in somebody who doesn't have that to explain their neutropenia. And then I think it's also important that we incorporate these reference ranges into treatment protocols, because again, a lot of these patients are being excluded from clinical trials, or having their dose reduced, in certain chemotherapeutic agents or rheumatologic agents due to this, despite there not being, increased risk involved. And so this was just a paper actually that looked at a number of different, tools. I think the most common one that people are aware of is the GFR, where, in many locations still there is a race adjustment to the GFR for patients. And there have been studies that have been published that have shown that this adjustment for race in the GFR have led to, many Black patients getting inadequate care. So being listed for renal transplant much later than they should have, being, receiving dialysis a lot later than they should have, based on this race adjustment for the GFR. So these are a few within like hematology oncology, but they're really within kind of every different field of medicine. We have these race adjustments that oftentimes are quite detrimental and tend to lead to increasing health inequity. So this is from that same paper in the New England Journal that really looks at how we incorporate race into some of our algorithms or calculations or reference ranges. And they really talk about, when is it appropriate to do that? When is it appropriate to have race incorporated into these things? And they really say that you need to meet these three kind of criteria, right? So is the need for this race correction based on robust evidence and statistical analyses, right? And so I think, at least within the hematologic reference ranges, it is not. They also, note that there should be a plausible causal mechanism for the racial difference that justifies the race correction. I think this is incredibly, problematic, and is probably where a lot of this falls apart, is that, again, race, right, is not based in biology. And so there may be a causal mechanism in terms of racism or social determinants of health and health inequity, and how Black patients, have a different experience in the world than white patients have. But that's not, based in biology. And so, we really need to look at what the actual factors are. And then lastly, would implementing a race correction relieve or exacerbate existing health inequities? And unfortunately, if you look at all of these, really, the risk in all of them is that generally, when you have incorporation of these race corrections, is that the already marginalized group, whether that be Hispanic patients or Black patients, or whatever patients they happen to be, it tends to be that they fare worse. And so I think in general, these race corrections very rarely help relieve health inequities. So with that, I'm going to change gears slightly to sex and reference ranges, which I think is kind of a newer interest of mine. As I got, to thinking more about these reference ranges and them being based in these social constructs, I started to think more and more about reference ranges in general, and hadn't really ever thought about the fact that our reference ranges, again, for anemia do differ based on sex, and that if you look at them, hemoglobin and reference ranges for boys and girls are equivalent up until the point where females reach menarche, and then they diverge. And so the World Health Organization, defines anemia for a man as less than 13 and for a woman as less than 12, up until the point where women reach menopause, and then a few years following menopause, the cutoffs for anemia reconverge at that point. And so when I am talking about sex and gender, again, I want to be really clear on what terminology I'm using. So again, sex typically refers to the biological aspects of an individual. So the anatomy, chromosomes, hormones. It's generally male or female, though not always, and is assigned at birth. Gender is different, is a social construct, and is typically more related to behaviors and attributes. And, at least within our society, these labels of like masculinity and femininity. So here we are talking more about sex and gender, and kind of the biology underlying that. So going back to the WHO definition of anemia as being the pathologic condition where the number of red blood cells is insufficient to meet the body's physiologic oxygen carrying needs. So when I was thinking about this, I thought, okay, so by defining anemia differently between men and women, or we say, okay, when you're a boy and a girl and you're young, then you have similar oxygen carrying needs. And so anemia is defined similarly. But then when women reach the age where they're able to bear children, they don't need as much oxygen, is what we're saying. And to me, that doesn't make any sense, because I would kind of think the opposite of that, right? Where, okay, if your body is trying to, prepare to create another human inside you, that maybe oxygen carrying needs would be important. And so what is this truly based on? Because it doesn't seem like it's based on this definition about oxygen carrying needs. So looking at this data, the thresholds for anemia and that differential between men and women was actually set back in 1968 and was based on 4 publications and then a few unpublished correspondence between some people that is not really something that you can find. And what it actually, if you look at the actual data that is cited when the WHO defines anemia between men and women, only one of these 4 publications actually looked at iron status, because in my mind, I thought, okay, I don't think that women, all of a sudden when they are getting ready to, their bodies are ready now to bear children, that they require less oxygen. I think maybe it might be that women menstruate and lose iron and become iron deficient, and we normalize that. And so when you look at these 4 publications, only one of them actually looked at iron deficiency. And what that publication actually showed was that if you replete the women with iron, that the men and women actually have equivalent thresholds for anemia. So within that paper, that again is what is used to support the idea of these differential hemoglobin thresholds for men and women, they actually say that, probably subclinical unrecognized iron deficiency in the so-called normal material needs to be ruled out by giving supplementary iron. And so they did that. They took a subset of the participants in the study and gave them iron. And this is what they found. So you can see here they had 102 men in total between the ages of 15 and 69, and then 40 women in total between 15 and 69. And they had, initially, if you look at the entire population of men, their hemoglobin prior to iron was 15.6, the mean hemoglobin, and after was 15.6. And again, I think I should be clear here that I don't think that necessarily men and women should have equivalent levels of hemoglobin, because there are hormonal effects, especially from testosterone. But I think that lower limit of normal should likely be more equivalent. And they did find that in this paper. So basically before the iron, the mean hemoglobin in women was 13.9, and afterwards it went up to 14.2. And here you can see the black continuous line is before the iron supplementation, so this Gaussian curve that they're using. And then after iron supplementation, what you can see is that really the levels below 13, or kind of that cutoff that we use in men, really disappear when you replete women with iron. But despite this, this is the publication that supports this differential cutoff of the hemoglobin for women of 12, despite the fact that when the women were actually iron deplete, that cutoff really should be 13, similar to what is seen in the male patients. So I'm not sure if when they were writing the WHO guidelines that affect the entire world, they just didn't read the paper carefully, or they were just kind of committed to having a differential cutoff. As I mentioned, I think, so we also wrote a paper about this that was published in Lancet Hematology, talking about how this really leads to health inequity. And we actually got, a response to our letter, which we then responded to. And the author of that letter was a hematologist that felt very strongly that, this wasn't due to unrecognized iron deficiency, but was rather due to hormones. And there is an effect of hormones. We do know that testosterone causes, proliferation of your erythrocytes. It can cause erythrocytosis, elevated hemoglobin. And we do see this, right? Like, it's why if you see a patient who has polycythemia, you should be asking about exogenous steroid use or, testosterone. And that is true. The relationship of estrogen to, your ability to make red blood cells, it's a little bit more questionable, and the literature is mixed. So it's a little bit unclear. But I think these really contribute to kind of that mean and higher level cutoff of hemoglobin, and less to the lower limit of normal that we use to define anemia. And interestingly, the author who actually, wrote back and told us that we were wrong, we actually, in our response to his letter, cited his own paper. So he actually, this was a study that was done in men with benign prostatic hypertrophy. So they were treated with something that was would block testosterone, so that their testosterone levels would go very low. And what they found was that the hemoglobin level did decrease when you blocked, testosterone in these patients. But what they did find is that the hemoglobin levels really didn't drop below that 13 cutoff. And so, men without testosterone really still are not dropping below that. And that there was really also no change in serum erythropoietin levels, which is, how you can kind of see if your body thinks, you should need more higher levels of hemoglobin. Unfortunately, I think with having the differential reference ranges for women for anemia, we also have in many hospitals, including my own, differential ferritin ranges, which really exacerbates the problem, right? Because we have normalized low levels of hemoglobin, but we're also normalizing low levels of ferritin, and those tend to kind of reinforce each other, right? So if I have a patient who comes to me, and in my lab, ferritin of 7, if you are a menstruating woman, is considered normal, even though we have lots and lots of data that's really not sufficient. But that's, you know, labeled as normal within my lab. And so they'd say, okay. And then, you know, maybe the patient say, I heard the ferritin needs to be higher. And the doctor looks and says, oh, well, you're not anemic either. Look, your hemoglobin is 12. But again, so these, you know, tend to kind of perpetuate this vicious cycle. So this is unpublished data that is actually from Oregon and Washington, some colleagues of mine that looked at these lower limit of normal ferritin reference ranges, and they are incredibly variable. So there actually, you know, are some labs, few, but some labs that have a ferritin cutoff of 1. These particular colleagues are very passionate about the fact that the ferritin cutoff for all people really should be 50. But as you can see here, where there is data where you know, there was different cutoffs for men and for women, the male cutoff is always much higher than the female cutoff. And unfortunately, you know, these levels do go very, very low. I would encourage you all to really look at the ferritin levels when you order them on your patients, because as I mentioned, you know, the reference ranges are very, very low and are probably missing a lot of iron deficiency in our patients, especially, you know, the older patients as they get closer to adulthood. It's a little harder to define normal in kids who are growing quite rapidly. And so there's not really a consensus, but in adults, really, among hematologists, the most common consensus is around 30 for a minimum for your ferritin. And what they found actually in this same unpublished data from Oregon actually is that the vast majority of, you know, there's a huge segment of the population that has these lower ferritin levels, but that they would largely be missed with these different lower cutoff ranges. So this is also unpublished data just that I have looked at myself, looking at NHAIDS data. So this is data from the CDC, where they take, you know, a large group of the population and follow them. They have, you know, everywhere from babies up to seniors, and they collect data on them, on their health history. They get labs, they do a physical exam, and this is, you know, kind of thought to represent the general population of the United States. And as you can see here, looking at like the mean hemoglobin in these patients, if you just take all the patients and you exclude, like, you know, patients that have an abnormal MCV, so you can see the mean hemoglobin for women increases really substantially, whereas, you know, there's not a ton of change in the males, because there's really not, you know, a lot of iron deficiency in males that, you know, unless there's something else going on. And then as you, you know, also exclude, you know, patients with a low MCHC and start to exclude patients with low levels of ferritin, the mean hemoglobin in women really kind of continues to increase, versus in men where you don't see a lot of change, which is, you know, what we would expect given that men really shouldn't be having iron deficiency. And similarly, this was kind of the change in that 2.5% level for hemoglobin, looking at ferritin, you know, all the way out to higher levels. And as you can see, as we remove the patients with low ferritin levels, the female hemoglobin cutoff continues to increase, whereas we don't see a lot of change in the male cutoff, just kind of illustrating how frequent iron deficiency is in our population. And this is just kind of another illustration of that same thing. But I think, unfortunately, what we know about iron deficiency is that it really is actually increasing in all patients. And so if you happen to be seeing that in your clinics and, you know, have noted that, you are not wrong. This is a paper that actually looked at the United States and kind of the time period of the last 20 years or so. And what they found is that for all of us, we've had, you know, a significant decrease in our overall iron intake. Some of this is dietary choices we make, such as, you know, people are eating less red meat, eating, you know, low carb. But there's also actually been, when they just look at like foods that people eat, the actual foods that we're eating have less iron than they did 20 years ago. So, you know, this is going to exacerbate this issue, you know, more in females than in males, but also being seen in males. And I think a lot of us think, at least in hematology, of iron deficiency as being somewhat benign, but these graphs on the left actually show over time mortality. And so what you can see, the bottom three are non-iron deficiency anemia that's nutritional, hemolytic anemia, aplastic anemia, and all of these are mortality, right? And so the mortality from all these different conditions is decreasing, where actually the mortality for iron deficiency anemia is increasing. And it's, it's quite low, and it's uncommon for patients to die of iron deficiency, but it's not zero. And the fact that it's increasing is definitely concerning. And so I think that this is likely to be an increasing issue over time, and will probably contribute to even more differential cutoffs in men and women if, reference ranges continue to be reevaluated. And unfortunately, in women, in addition to that decrease in dietary iron, we know that women of today are at much higher risk for iron deficiency and have higher rates of iron deficiency than they would have, historically. We know that rates, I'm sorry, not rates, but like the average age of menarche is decreasing with time. And so patients are starting to menstruate earlier. They have fewer pregnancies than they did, long ago. And so pregnancy, is a 9-month period, 9+ month period that you're not menstruating and not losing blood. Similarly, breastfeeding. Patients are, breastfeeding less, just even due to the fact that they're having fewer pregnancies. And so that also is less amount of time away from that menstruation where you're losing blood. And then we also know that women are having menopause later in life. So kind of if you look at the full lifespan of women, really they are having, just more menstruation, more menstrual blood loss over the course of their life. So are going to be more likely to be iron deficient than they would have been, 100 years ago, in addition to, that decreased dietary intake. So I think iron deficiency is going to continue to be an issue. And as I mentioned, unfortunately, when the mother is iron deficient, that affects the baby. We know there's lots of data out there that iron deficiency in infants, has a lot of downstream neurocognitive impacts. And so I think this is something that is likely affecting, a large percentage of our patients. Unfortunately, on the upside, I think the World Health Organization has actually identified, the prevalence of anemia in women of reproductive age as one of, their top goals. They've been working, I think, with the March of Dimes, and their plan was to achieve a 50% reduction in anemia kind of worldwide in women of reproductive age. I think that that is a lofty goal, and at least when we spoke with the WHO, they were not really on track to meet that goal. And I think what was really educational for me at the WHO, and hearing the conversations around, these anemia cutoffs and what the WHO is going to ultimately say anemia should be defined as, is that there's a lot of politics around this and a lot of investment from the countries and from governments of countries to define things in a certain way. Because, for example, if you don't provide great nutrition to your citizens, and you don't provide, clean water and all of these things that contribute to people being healthy and not, having these treatable causes of anemia, then, you may be able to reach these goals. But if you don't provide that, if you're not providing those things to your country, you probably aren't that invested in doing so. And so, what the WHO defines anemia as, may have a lot of repercussions for you in terms of if you're meeting those goals that the WHO is setting. And that, unfortunately, if we, change the threshold, even this goal that the WHO has as a whole is going to be much more difficult to attain. Especially in light of the fact that they're already, behind on this goal of achieving this. And so this is just kind of an overall map for you on the global prevalence of anemia. And this is currently based on that definition of anemia as less than 12, which I think is too low and is incorporating a lot of very treatable iron deficiency. But if you think about if we increase that to 13, equivalent to what the cutoff is for males, then these numbers are even higher, right? And so you would have some areas of the world where definitely over half the population of women would be considered to be anemic. And again, in my mind, that is, this is a very treatable thing, and iron, iron supplements are something that can be done. But if you're a country that, is not invested in health, that is not something that probably you're interested in doing in terms of increasing your population of patients that are diagnosed with anemia. So in conclusion, I think we know that many causes of anemia and neutropenia, as well as other hematologic disorders, do have a genetic basis, but that race and ethnicity really are very imperfect correlates for genetics, and oftentimes, are not correlating for what we think they're correlating to. I think that differential thresholds sometimes are needed, for example, in the case of like Duffy null, but these really should be based on biology and genetics, not social constructs such as race and ethnicity. And I think really in general, it's important to remember that historically, a lot of the trials and data that we have really stems from data that we have from white men. And there's, that's what they did at the time, and that's the data that we have, but we really should be thinking twice about that and not necessarily just assuming that we can extrapolate all of that to these other groups of people that may be very different in terms of what's going on with them. So I will wrap up there, and I'm happy to take any questions.
Thank you, Dr. Weyand, for that fascinating presentation. Let's see, anybody has questions or comments for you? I'm watching the chat box. Okay, go ahead and ask the question. I see a hand raised.
Hi, this is Nandini. I'm an outpatient pediatrician. I actually have a question related to like my own health in this way, because I'm of Indian origin and I'm mostly vegetarian, with only some fish occasionally. And I'm curious, in relation to, you were talking about the dietary changes that have been happening in our society, with the vegetarian and vegan population. It's an entirely different picture, and most of the country of India is vegetarian because of Hinduism. And so, like, how does this impact these populations specifically in terms of what we should be supplementing with, or educating them about for dietary intake?
Yeah, no, it's a great question. I mean, I think we have, heme iron from meat sources that we know is much better absorbed. And so if you're not eating, those products, I think it can be difficult to get in enough iron because you just absorb such a smaller percentage of non-heme iron. Although, there are good sources of iron in a lot of, vegetables and stuff. It is non-heme iron, so it's just a smaller proportion. I personally am of the belief that, like, for anyone who's menstruating, like a multivitamin with iron should just kind of be a given. I think, unfortunately, as we're learning more and more, I think historically, and even still, a lot of my colleagues think, well, if you're not anemic, then iron deficiency doesn't matter. But there's actually so many biochemical reactions in our body that actually rely on iron as a cofactor. And the more work that's being done on iron deficiency with completely normal hemoglobin levels, there are so many associated symptoms that I think people aren't even necessarily aware of. I'll see patients and they're like, I feel fine. And then we'll get their iron up to a good level. And they're like, I guess I didn't feel fine because now I actually feel good. And I'm, able to do all these things I wasn't previously able to do. So I think, for people that can have levels checked, I think that's helpful, because an iron supplement is relatively easy to do, especially now that we're recommending, once a day, every other day. Dosing really is probably optimal for absorption. But I think it's a great question. I think it's hard to know also, because I think when I see patients in clinic and they kind of try to tell me about their diet, I will oftentimes have them, we're lucky we have a nutritionist in our clinic. And so they'll do more of a deep dive into how much iron they're likely getting. But to me, I think it's super hard because some patients, that are vegan or vegetarian, or after they've met with a nutritionist are getting like really great iron, and then others are getting, not great iron. And there's actually a really nice list on, if you go to like the Red Cross website, there's a list of like iron rich foods, and a lot of them on there you would be surprised by. I think every time I look at it, I see something where I'm like, wait, that is iron. Like watermelon, like I would have never thought watermelon was a source of iron, but like there's, I think, a lot of foods that people don't necessarily think of, that have, that are good sources of iron that can be incorporated. But it is tricky because I think everyone's diet is so very different. And I think it's also difficult even for patients to really, recall and report exactly what they're eating.
There's okay, go ahead, ask the question. Dr. Herndon, you can ask the question. You can put it in the chat box. There's a comment from Dr. Gail Tomlinson, who is our Chief of Hemonc. Thank you. Very interesting perspective on impact of social determinants of health on everyday pediatric practices. So are we going to have new studies looking at standards or ranges of levels for hemoglobin and ferritin in this country or worldwide? Or?
Yeah, so it's interesting because I think, there were those studies that everything is based on. The NHANES data that I've looked at a little bit, it is like publicly available through the CDC. I think actually most labs kind of do their own reference ranges. So the WHO, states like 12 and 13, but I know even within my lab, like for some patients, the cutoff is like 11 and a half. And, so based on like the lab they're using and what exactly their reference range is, it can even sometimes be lower than 12. So I think that also is a little problematic, is that it totally depends on the lab that you're in and what tool, what reference interval they've decided to use. And there's a lot of variability in how they define the reference population. So some reference intervals do a really good job and say like, we're gonna, exclude patients with all of these conditions and, with these abnormal labs or whatever, and others seem to not really do as good of a job. So, but I know, we're all busy, and oftentimes when you get labs, if it doesn't flag as abnormal, then you aren't like looking at to say like, well, is this like reference interval actually appropriate? Or, what I mean? It just is, I don't think that's something that people are thinking about. I think we look for the red flags that let us know that things are not within range.
Any other questions, comments? Is 8:31. Thank you very much, Dr. Weyand, for that fascinating presentation. Thank you all for attending this morning's Grand Round. I'm going to conclude and have a wonderful Friday. Thank you all.
Thank you.
Thank you, Angela. Thank you. Bye-bye.
Bye.